Well, the roots of this project actually come out of work that we collaborated with Katie Maslow on back in the 90s, and was focused on managed care, thinking that managed care was one place where maybe you could argue that there's cost savings to this kind of preventive, informed, consumer-focused, so that there might be a willingness for managed care companies to fund it. And in fact, when we started the project, we had a commitment from one managed care organization that was going to fund it if we got the outcomes that they hoped, and we got the outcomes that they hoped, and they didn't fund it. And that's been a familiar story right along, and we're still wrestling with that, even in terms of the VA system, as we have very positive findings from our study. So marketing to consumers, that was a whole nother ballgame. I mean, I believed, truthfully, that people would be willing to pay a small monthly fee to have this coach there whenever they needed it. And these are caregiving families in difficult, complex care situations. I thought, well, let's do it like a health club. $50 a month. So we actually wrote a business plan. I'm in a service organization, so we can't lose money on everything. We can lose some money on most things, but not a lot of money. For $50 a month with a full caseload, you could break even and have good supervision, a good record-keeping system. We tried everything. Television, radio, thousands of radio ads, newspapers, health fairs, churches, senior centers, other organizations, city government. Believe me, we blitzed the community. No matter what we did, we got a trickle of people who were willing to pay. We lowered the price. We gave coupons, sales. We ran a sale. A trickle of people. 3 months for the price of 2. Lowered the price to $25 a month. We still got a trickle. Then we tried to give it away. We still got a trickle. We stopped offering the service. The organization, we don't offer it anymore. The successful circumstances that we've had have been when it's embedded within an organization's larger structure. So within a managed care plan, within a AAA, within an Alzheimer's Association chapter that already has a constituency, using their other programs. So those have been the successful marketing experiences that we've had.
This is a great question because, I live and breathe the transitional care model, as does our team, but some people look at you with glazed over eyes when you explain to them what you're going to offer them as a service. And they don't always understand at the bedside during a crisis or during this acute episode of illness what you're now offering them. But they know it's home care on some level, and they're not quite sure what they've bought into, but sometimes they've agreed to participate. For us, I think having a supportive health system, their interest and their willingness that we've showed time after time this works, why aren't we adopting it? And having a health system willing to see that this can benefit not only the health system, but it benefits, and from a cost perspective, because they're looking at the future, but also can benefit our patients and keeping them out of the hospital. This is a frail population. This is a chronically ill population. Being in the hospital is not the best place for them. How can we provide better care for them? I also think our home care agency, being who they are and how they've also sort of emerged, has been also a wonderful experience. But we've had to work with them and the insurance companies, and that is, I think, our biggest challenge in finding ways to bring this to large scale and reimburse it. It's promising. Our research findings show that it's a cost-effective service. So, in fact, the Coalition for Evidence-Based Policy, which is an independent, nonpartisan group, has recommended large scaling of this intervention and our model based on the evidence to date. So how do we get it out there? And it's a great question, and we're working on it. And I think talking with Kaiser or talking with other large health systems is the way to go with something like this.
Well, I think many of you are old enough to have lived before magnetic resonance imaging. It's only been around for about 20 years, but all of you live within about 10 miles of an MRI scanner. Not much longer than that was the advent of hemodialysis, and all of you live within probably 20 miles of a hemodialysis center. Those are multinational corporations now that run hemodialysis centers. It's a really complicated procedure. It takes a specialist, you know, you have to have a nephrologist that's part of it. And that's a huge, you know, distribution system for about the same number of people that have dementia. And the difference is it's paid for. And there's, you know, people come up with crafty ways to get the distribution system in place. Of the, you know, 8 to 12 things I listed on my list of things a primary care doc is supposed to do, most of them are paid for. I mean, I can get an MRI literally by going to my computer and saying MRI. I can't do that with any of the things we talked about this morning. And the ones that are there were there, but they're not there tomorrow, you know, in terms of the home health agencies or the, and it's just a lot harder to track. The medications are the easiest of all. It's way easier to write a script for a medication than it is to find a psychotherapist or an advanced practice nurse or a home health agency that might do this. It is easy to make a referral to the Alzheimer's Association, but that's a big jump for people. You know, to knock on the door or pick up the phone to the Alzheimer's Association. So sometimes it helps writing a script for that, so it seems a little bit more official. So my point is that for our intervention, the parts that I said I thought were the working parts aren't paid for. And so how do you get it in place? Well, you have to have a champion at an individual healthcare system go to the boardroom and make the argument for the downstream savings. And that's how you get it done. And you're competing with the other people that are trying to, you know, make the same argument, and you're competing with the people that want to put in the PET scanner that's paid for, and maybe even generates revenue. Having said that, it wouldn't all be solved just because we were able to pay for, say, care management or our protocols, because then we'd all be recruiting the same Florence Nightingales, and they're not out there. So there's a whole workforce issue, and then they're not yet integrated into the system. A lot of people mentioned today, you know, how could you get it more seamless? And I don't think anybody has done that on a large scale where you have these, you know, very smooth transitions across what essentially are medical care agencies and social service agencies.
One last question, and then we'll open up the discussion for the audience. So if you were king or queen for today and you knew the federal government would do what you wanted, or you knew the private sector would do what you wanted, what would be your top thing that you would cause to happen that would help advance this intervention or others like it? I can start over there.
Yeah. I was thinking this is like that thing, if you had one wish, what would you wish for? And then you
Yeah,
wish
that's
for
pretty
more
much
wishes. And then
No, that's not good enough. No, that's not. Very good answer, but not.
yeah, start over there.
Yeah.
Well, I think as you've heard multiple times, these things are all connected. Many of us have the sense if you do one of the things and not the other things, it's not going to work. So you need all of those working parts to work together. And so what I would like to see are the financial incentives and the regulatory incentives to put the whole package into place. And that means as a primary care doc, I ought to be able to order you know, one of the interventions, and it was as available as the Starbucks on the corner, just like I can order a serum sodium, and you know, I can get it done anywhere in the United States. But at the same time, I think that package, that regulatory and financial package, has to have embedded within it the resources to build the workforce. Then I think you would have the incentives aligned for these interventions to take place. I do think, for better or for worse, if I tell a patient about any one of the interventions that you heard that didn't come out of an MD's mouth, it has more weight. I don't know why. It's what it is. If I say, I'm going to write you a prescription to go to the Alzheimer's Association, it's way more powerful than if I say, you might want to go to the Alzheimer's Association. You know, it seems like it was right there with the MRI or, you know, the drug that you gave. And that requires then everything that I said, and then you have to retrain that healthcare system that, you know, for this type of patient who doesn't have strep throat, you're just a part of a big machine that we're trying to put in place for that family.
You should have gone last. No, I think that was incredibly well put. You know, I think this, again, the importance of change in policy to be able to support these evidence-based programs and different types of interventions. It's not a one intervention fits all. I mean, I think, and I do agree with you. I think that having a script, so to speak, written by your primary care provider or coming from that office, whether it's the nurse practitioner or via the physician, whatever the case may be, coming from that office holds a lot more weight in getting someone to potentially act and do a behavior change by going, even just making that first phone call or going to the website or accessing a service, an evidence-based service or program that might be available. I think this, the importance, we talked earlier about having objective measures, that we can use that aren't just, self-report. I think we need to spend a little bit more time focusing on that. But in order to get to that, we obviously need support. We need the policy changes and spend a little bit more of reimbursement on that.
I think I'd like to see a better coordination among these evidence-based programs, and not just the ones for dementia, but other evidence-based programs that are out there that are relevant for people with dementia and their caregivers. Sort of a coordination program for evidence-based care, packages of complementary evidence-based programs, and then integrating those in with the larger health services, community-based services. I think a coordination program like what I described for you, this coaching model, I think could help families know which ones to use, when to use them, how to draw on the information they could get from these very complementary groups of evidence-based programs. So it's kind of a time, I think, to have a little more rational delivery of these programs which are now available, and that we can sit here and talk about a dozen or so of them.
Okay, so I think it's time for people to ask questions.
So I was struck, David, by your last comment, and it just made me think about the options counseling initiative under the Aging and Disability Resource Centers. So how do we take all that you've learned, which is so practical and so important to older people and their families, and infuse that into larger systems? Because to me, this seems like a real natural in terms of training. You're talking about options counseling. So I'm making a plug for that, as our ACL colleagues are here.
I've recently been in discussions with the people looking at options counseling, and it's amazing how similar this care consultation program is to options counseling. Really the only difference is whether there's an in-home component or not, because we have all telephonic, computer-based. So yeah, options counseling, I think, could help people weed through the evidence-based programs and make decisions about when to use the right ones, which ones to use, and then to draw on that knowledge at some later point.
Just to finish it out, because what I heard from all of our speakers, and you were just terrific, is that people want to have somebody to talk to. And it may be on the telephone, in person, or through email, but it's having that trusted one individual who can be with them and support them, and I think that's critically important.